Minutes past 8 o'clock, Lotus FM, the Breakfast Express, voted Station of the Year 2021, and you're listening to the award-winning Breakfast Express show. We're coming to you throughout South Africa. We're worldwide on www.lotusfm.co.za, and you can catch us on the DSTV audio bouquet anywhere in the country or the continent. Of course, that's on channel 808. Now, a fifth wave of COVID-19 is anticipated to hit our shores within the next few weeks, fueled by an easing of restrictions and a new variant.
So the new variant, known as Delta Cron, is a mixture of Omicron and Delta variants, and it's been spreading in France, Denmark, Germany, Holland, the US, as well as countries in Asia, and has already appeared in South Africa. So is the pandemic nearing its end, or is it wishful thinking? Should we be concerned about Delta Cron, and what else can we expect for this year?
Yes, some important questions there, and of course, to get some insights, we're once again engaging the expert in the field, not just in this country, but internationally recognized as well, the good Professor Salim Abdool Karim. Good morning, Prof. Karim, and thank you once again for joining us.
Good morning, O'Neill. A great pleasure to be with you, and good morning to all of the listeners.
Well, fantastic to have you back as well, a sound voice, and it's always good to hear from you, Professor. It's been a while since we chatted. It seems like better times, if that was just used as a yardstick. Where is the pandemic now? Is it coming to an end, or do you think it might be wishful thinking?
Yeah, I think as we look at this epidemic and the way it has unfolded in South Africa, we go through waves, and the waves are pretty consistent in that they occur roughly 3 months apart. So based on that, we can expect, if the past trend continues, that we'll see the next wave in early May. Now, what's critical for that wave to occur is whether there is a new variant. At this point, Delta Cron is not clear as to whether it's really going to be a threatening new variant. The new variant, when it comes about, will be called pi. That's the next letter in the Greek alphabet. And when pi comes along, it will be a variant that spreads faster than Omicron, otherwise it won't be able to displace Omicron. And it will have some degree of immune escape. It will be able to escape past infection immunity and some vaccine immunity. So that's what we are expecting. Whether it will actually occur and what it will look like is anybody's guess, because this virus, the way in which it mutates, is unpredictable. And we saw that with Omicron. Nobody predicted that we would see Omicron. Nobody predicted we would see Delta. So it's in the same way, we don't really know what the next variant looks like. But we can hope. We can hope it looks more like Omicron than it does like Delta. But that's just hope. It's not based on any real facts.
I don't know if you could simplify this question, which I'm afraid might sound ridiculous, but I'm going to ask it in any way. What do you know happens in this engine room where variants are born? I mean, you know, what are some of the conditions for this, let's call it a perfect storm, where a new variant somehow pops up?
All right. So there are 3 theories, and they're just theories about where variants come from. So the one theory is that they actually are incubating anyway, and they're circulating, and we just don't know about them. That's an unlikely theory. The second theory is that the virus goes into animals, and in animals, it makes a lot of changes and then comes back into humans. Now, we have seen that occur in several instances, and remember that the coronavirus can infect a whole range of animals. I mean, it infected tigers in the Bronx Zoo. It infects normal cats and dogs that are in your home. So this coronavirus can infect lots of different animals. So that's one theory. It's not a theory that's been, where there's much evidence to support it, but it's a theory. The third theory, which seems to be the most plausible, is that the virus infects individuals who are immunocompromised. So these are individuals with advanced cancer or transplant recipients or advanced forms of immunodeficiency like HIV, or they have, these very severe cancers. So these individuals can't clear the virus. So normally, you and I, if we get infected, we would be able to clear the virus in a matter of about 7 days. That's the basis of quarantine. But these individuals who are immunocompromised can't clear the virus. So the virus causes a persistent infection for several months. And during that time, it accumulates multiple mutations. Now, for that hypothesis or that theory, there's actually growing evidence. There are now at least a dozen papers that have shown that, for example, in a patient with leukemia, that patient was able, that when that patient got infected, that patient remained infected for over 6 months. And the virus 6 months later was very different from the original because it accumulated mutations. So it's quite likely that immunocompromised people, when they get infected, remain infected for a long period. The virus grows in them, but because they can't mount a response to clear the virus accumulates mutations, and then eventually the virus then jumps back into the population, and then it spreads. So that's what we think is the main source of new variants.
Now, Professor, it's quite a good answer you make there, and I can, understand what you're saying. Now, it's safe to say it's been with us for about 2.5 years. We just last week had 2 years of lockdown, if it's something that we could say we commemorated or acknowledged. But what about long COVID? What is your research, your readings, your studies has found now in terms of symptoms or damage or what is still persisting within people that you've had sight of or you've learned of?
One of my biggest concerns is that long COVID is still to have its full impact. So let me just start by defining long COVID, because it's not an easy concept for those not familiar with it. So the traditional way in which we describe the coronavirus infection, COVID-19, is that you get infected, you either clear the virus or you get some respiratory illness, but then eventually you recover, and in a very small proportion they will pass away. Now we understand that there's a proportion of people estimated to be between 10% and 20%. So between 1 in 10 and 1 in 5 individuals who get COVID-19, and whether they get it very mild and even asymptomatic, or whether they get it severe, it doesn't matter, that they will go on to getting long COVID. And long COVID is a whole series of different symptoms, but mostly what the patients complain in my clinic is they talk about brain fog. They feel lethargic, they feel like they can't concentrate, they can't read. It's quite a debilitating condition, because for people who want to get on with things, it's holding them back. So this long COVID has an immunological basis, because you've cleared the virus. It's now the immune system that's causing this problem. And if you think about what we are seeing, the evidence is now progressively accumulating. So there's a study released that shows 1 year after a group of people were infected with the virus and got COVID-19, some of them didn't even know they got infected, so they were asymptomatic. Most of them were mild infections. 1 year later, the risk of heart disease and stroke was 50% higher. Now that worries me, because if you take that so many people got COVID in South Africa, if we're going to see an increase in heart disease, and we're going to see that down the line in a few years, we've been dealing with the waves of infection. We're then going to be dealing with the tsunami of all the long-term consequences of COVID-19. And just recently, a paper was published that shows in quite a prestigious journal, Nature, it did brain scans on people before and after they had COVID. And it shows that people who have COVID, even if it's mild COVID, they lose brain mass. In other words, their brains become smaller. They lose up to 2% of gray matter. Now, most of us, we just use a small part of our brain, so losing a little bit of brain may not be a problem. But to individuals who are, elite sports people, or who are, academics and people who are in professions where they use a high proportion of their brain, this will impact them. And the evidence is already accumulating for that, that performance is compromised.
A layman's question to you, Professor. We know that it attacks your respiratory system, your lungs are affected, a bit of your breathing. Where then is the link to the brain?
So in these studies, what they have shown in a proportion of these patients, they did lumbar punctures. In other words, they put a little needle in the back and they drew out the fluid that covers the brain and the spinal cord. It's called cerebrospinal fluid, CSF. And what they showed in that CSF is that there are antibodies against the virus, and the virus is even present in some instances. So this virus is not just a respiratory virus. This virus can infect any cells that have this receptor called the ACE2 receptor. And that receptor is in every part of your body because it's in the little blood vessels that permeate the brain and everywhere else. So what is in fact happening, we think, in a proportion of patients, is that they have an infection that goes to the brain, and the brain responds, and so they get antibodies and they clear the virus. And then they have to deal with the long-term immunological consequences.
Right. So from everything you're telling me, it still holds true that you should do everything in your power not to get COVID-19.
Definitely. If there is one lesson in all of this, don't get COVID-19. Do everything you can to avoid getting COVID-19. And the primary thing you need to do is to get vaccinated. And we now have good evidence to show that 3 doses of the vaccine do pretty well in protecting you even against Omicron. And, in addition to vaccination, there's just some good common sense measures. If you're going to go into a crowded indoor space, put on a mask. It's not rocket science about what needs to be done. But most of the risks we're dealing with nowadays are in indoor situations. Most of the outdoors are perfectly safe. Enjoy yourself, especially now when the cases are low, that the risks in the outdoors is quite low.
Now, I've been called out a few times in terms of our infection numbers that we see by some of my colleagues or family in England to say, you guys are really not testing as much. Now we see numbers in Australia at 60,000, Japan 32,000, Thailand 21, South Korea 347,000. What's different there to what's happening in South Africa?
So there's, firstly, we are testing a lot. Whether you're testing enough or not is a subjective matter. We use something called the positivity rate. And when your positivity rate is, between sort of 5-10%, in that sort of range or below 5%, then you're testing enough. Because most of the people you're testing, 19 out of 20 people you're testing are negative. So that basically tells you you're testing enough. But when we go into waves, what happens is that a large number of people have very mild symptoms. They don't even know they have the disease. And so they don't come forward for testing. And that's because we have a higher proportion of younger people in South Africa than they have in Japan or in Australia, because we are a younger population, actually not just in South Africa, but the whole of Africa. So younger people tend to more often get a silent infection, whereas as you get older, when you get above 60, a high proportion of those infections are clinical illness. So that's one of the main driving reasons. There's a second reason, and that is that some people just don't want to test. And part of the reason they don't want to test is because they sort of know they have COVID, and if they test, that means, they can't go to work or they're going to have to go into quarantine. So to avoid that, they don't test. And that's just silly, because part of the way in which we deal with an infectious disease is we try to reduce the risk of people who have the infection, try to reduce their risk of spreading it to others.
Professor, you've done a sterling job in terms of just your predictions, and I know that of course comes with a disclaimer. Last time we spoke to you, you said just after Easter, somewhere in May, and you still now, as we're coming to Easter, maintain that, and it looks likely. So having said that, what's your outlook on the pandemic, say, come the back end of 2022?
So if we look at the short term, if you calculate 3 months since the end of the Omicron wave, that takes you to around the 8th of May. So we can expect somewhere around the beginning of May, we should be entering into the next wave. Now, that's, the big disclaimer is, of course, we've got to have the new variant. So Pi has got to come into existence before then in order for us to have a wave, because we have a lot of natural immunity and vaccine immunity against Omicron and against Delta. So it won't be Delta or Omicron causing the next wave. It's more likely to be a new variant. And if we look at what lies in store, well, each new variant has to have two things in order to survive and become the new variant. And that is, it's got to be able to spread faster, and it's got to have some level of immune escape. Now, the virus has enormous potential to mutate. And so it will continue mutating, in my view. And so we can expect to see several new variants. But there's going to come a time, I don't know when that time is, maybe in 2-3 years, I don't know. There's going to come a time when the virus cannot continue mutating with an advantage. So the mutations will continue, but won't give it an advantage. And when we get to that point, I expect